Bedside grand rounds, the best teaching place. I would like to quote a Chinese proverb. When I hear, I remembered for one day. When I read, I remembered for a month. And when I saw, I remembered it forever. History. Sir William Osler from Johns Hopkins University introduced first time the bedside teaching as a new approach to clinical education in 19th century. Residents learned as faculty passed from patient to patient, explaining their methods of diagnosis and treatment and sharing them with everyone. Participation increased, and when these rounds moved from bedside to auditoriums, the traditional approach to grand rounds was created. By definition, a formal meeting at which physicians discuss the clinical case of one or more patients is termed as bedside grand rounds. Bedside rounds originated as a part of residency training, wherein new information was taught and clinical reasoning skills were enhanced. Bedside rounds today are an integral part of medical education. They present clinical problems in medicine by focusing on current or interesting cases. They are also sometimes utilized for dissemination of new research informations. Research on adult learning has shown that the adult learners must feel the need to learn, participate actively in the learning process, and have a sense of progress towards their goals. They also prefer to share the responsibility for planning and organizing their learning experiences. UG medical education has adapted to adult learning principles in the form of problem-based learnings. Patients with a complicated illnesses may benefit from a second opinion too, in case of diagnostic doubts, and may feel more involved in such instances. Unlike other specialties, we all know the ophthalmology is highly privileged. We have fairly healthy patients to interact with us, with their history quite well. We can see almost all the parts of the eye around and come to clinical diagnosis with relative ease. Teaching in an ophthalmic clinic need not be very elaborate at the expense of efficiency. In just a few minutes, a good clinical teacher can direct students' attention to what is important while simultaneously providing clinical care. Bedside examination and teaching seems to have declined for a variety of reasons in recent years. Some of them are increased patient volume, increased emphasis on electronic EMR recordings, investigations, etc. Some physicians fear that bedside teaching compromises patient satisfaction with their care, despite evidences to the contrary side, whereas others are limited by their own suboptimal bedside teaching skills. We end up in such scenarios where the bedside teaching is not present. We end up with treating topographies, visual fields, OCTs and CT scans, not the eyes and not the patients. Patient primary symptoms often remains unaddressed in our enthusiasm to diagnose the disease and treat it. To summarize, the fervent power of bedside teaching is that it makes patients and their illnesses tangible, thus helping the students to comprehend the disease in its entirety. History taking, physical examination, logical reasoning, clinical diagnosis, communication, professionalism, touch, respect, empathy, and most importantly, what it takes and means to be a doctor are best taught, exemplified, role modeled, and learned in the presence of patients and not in a conference room or a lecture theater. To conclude, the format and objectives of bedside rounds and expectations for what this type of lecture is intended to accomplish have changed since the inception of this approach to group teaching in medicine in the late 19th century, and these changes have parallel changes in the practice. Ophthalmologists, especially medical teachers, should come up with new strategies for restoring these bedside rounds, which may help clinical departments revitalize this once important approach for teaching and promoting professional development in medicine. Thank you.